So I thought very hard about what I would speak to you about today. You are the experts in this room. You are the people who have taught me about oral health. You're the people who I've worked with. I'm looking at Linda Neeson. What's that, in Linda, 1980, at the Harvard Division on Aging with Chet and others. And I've thought a lot about what might be useful. And I've also thought about our foundation. The John A. Hartford Foundation in New York City has been focused on the health of older adults since the mid-'80s, and we have made it an absolute mandate that we will improve care for older adults. Our 3 areas of emphasis are end of life, serious illness care, along with family caregiving needs, and age-friendly health systems. And so we're very, very passionate about moving the needle. We spent 30 years working on workforce development with nursing, medicine, social work, and interprofessional. And I know you've seen that signature work, which I was a part of as a grantee, not as the president of the foundation. But so exciting to be at the foundation at this very important time when so many of us are thinking about older adults. And so I want to thank Mike and thank the Santa Fe Planning Group for allowing me to come speak to you today and to really partner with you. So my passion for geriatrics and gerontology came early in my clinical experience as a staff nurse at the Beth Israel Hospital in Boston, where I would see patients and say to my outstanding colleagues in medicine, my patient isn't eating, what do you want, what should we be doing? They'd say, do whatever you want, not what I do. Okay, my patient is having difficulty going to the bathroom, has a pressure ulcer, do whatever you want. Okay. That was the best thing that ever happened to me. We spawned Niche. We figured out how nurses could improve health systems for the elderly, which is now in 900 hospitals in the United States. But also, it reminded me how important all of us are to the well-being of the entirety of the person when they're in any point of care, and in that case, it was the hospital. My master's thesis in 1977 was entitled Dentition and Nutrition in the Elderly. So this does not come as a new idea to me, and that happened because if you're practicing, I don't have to tell any of you, if you're practicing in the clinical arena and you see people whose mouths are in such deplorable shape, it is so heartbreaking. And what can you do? Nothing. So I want to talk about that and tell you that my passion is as strong now as it was then. And let's see if we can get underway. So what are we trying to accomplish? This is a gentleman named Mike. I met him at the Hebrew Home for the Aged in Riverdale, where we were doing a photo shoot because we thought it would be wonderful to refresh our pictures, but even better, you get to meet all these great patients. And so what are we trying to accomplish? What do you notice about this man? In this group, you should be able to say it. He's not showing his teeth, is he? So everybody, we're trying to accomplish a world where everybody can feel free to smile. And here's Mike. If you notice in this picture, I can just tell you, he's missing several teeth. And he's a nice guy, a friendly guy. He had lost a leg, he has diabetes, he has periodontal disease, and he's got a great smile. He does not have teeth. But we want a place where everybody can feel free to smile and feel good about it. That's really, really important. And here he is working on his rehabilitation, and a wonderful human being. So today, you know, the case for oral health is well known to you and to most of us here today. Your excellent white paper was so informative to me. And my thoughts with you today is really to think about impactful messaging. Why has it taken us so long, you know, since from the 80s till now to really get this, 60s, to get this impactful message across where we say to people, you should be concerned about the well-being of people's oral health, you know, and there are many of you give this speech all the time. So I thought, where's the messaging? Everybody in this room is a believer, or soon to be, or you wouldn't be here. So how do we get to the non-believers, and who should we be speaking to? So I'd like to make that point today, and having read your scientific papers, I'm going to take a different tilt and give you the 10 commandments of oral health. And I want to do that in order to get you rallied, to have fun with this conference. Yes, you're going to be talking deep science and how to move the dial at CMS and all those things. But let's remember the messaging and who we have to be speaking to every day. So these are the things that I'd like to talk about during my few minutes with you about what you must remember and what you must remember to convey as you passionately talk about older people. So the first one I would say to you is no ageism. Advanced age is not an opt-out for oral health. You must fight ageism. There's a wonderful group working on this right now called Frameworks. And Frameworks is rethinking the way we imagine geriatrics and ageism. It's really quite daunting to me how people can absolutely ignore the geriatrics and the fabulous success. The biggest success story of the 20th century was longevity. 1900, you lived to be 45. Double that, by the end of the century. That's a big deal. So we've doubled life, and now we have to double care. And that's what we owe these people. We save them and scorn them. That's not okay. So no ageism. The mouth is part of the body. There is an oral systemic connection. Mike just talked about the science. You all know the science. And that still is not clear to everybody with whom we work. There are 3 million plus nurses in the United States, 5+ million assistive personnel that range from home attendants to physician's assistants. There are so many people in this field that are not in this room. And so pushing out the fact that you have to be looking in the mouth, and I'll comment on that more in a minute. No oral health, no oral nutrition. If people can't eat, if their mouth is uncomfortable, you have to make the case that nutrition, the right balance of foods, and Dr. Alfano, with his PhD in nutrition out of MIT, has the right to get up here and talk about nutrition. I'm always so proud of Mike, and thinking about what kind of nutrition people will have with no teeth. Remember, we're talking big sky, big picture messaging that you have to say again and again and again. Don't chintz on oral care supplies, please, in our care settings and where you are. These are the famous toothettes. I don't care what you call them, they are disastrous and they're horrible. They do nothing. I don't know how much they cost, but somebody's making a ton of money on something that has zero efficacy. Somebody study that for me. As a nurse, I gotta tell you. What will nurses do if that's on the cart? They'll take their wallet out, they'll go down to whatever drugstore is around, and they will buy a toothbrush and come back when they're on the ball. So please take a look at those supplies. I remember one time there was, after the ARGs went through and there's a healthcare crisis in financing and everybody was trying to save money, the first thing they did was take oral healthcare supplies off the stock cards. That was awful. And it was Joyce Clifford at the Beth Israel who got them back and said that that was not happening, that we couldn't provide care. So please don't chintz on oral care supplies. And think about the efficacy of these ridiculous things that we do. No teeth does not mean no pain. And for any of you who have ever cared for a person who was edentulous, which I certainly have, the ability to miss a tumor, miss a bleed, miss any other kind of malformation of the mouth is very, very serious. And no teeth does not mean no pain. And so how are we messaging that to our nursing students and our physical therapy students and our family members? Family caregiving, the National Academy of Medicine just published a wonderful family caregiver report that reminds us that most of the care in this nation is being given by families. And so we have to help them. Educate. Most people do not know that Medicare does not cover oral health. This comes as a shock, if not a surprise to them. They don't know it, they need to know it, and that will be the rallying cry that gets everybody behind us as we move to CMS and say how important this is. People with dementia have oral health care needs too. I know that there are special dental services set up for people with dementia care, not enough of them, and certainly not enough for the future. But people with dementia have oral health care needs too, but we don't really look at that. And it was the wonderful, fabulous Jonathan Shipp, who died way too young, who one day when I was at NYU convinced him to go on rounds with me at the NYU Langone Medical Center to look in mouths. And of course, John stopped what he was doing and walked across the street with me. He was awesome. But he worked very hard to set up a clinical protocol that every person in that center could use to think about care, not only for people with extraordinary needs, but also what should be usual best practice. And there's not a best practice in our major medical centers or our hospitals like I love. I'm from Herkimer County, upstate New York, population very, very small. And I'm on the board of Bassett Health System, covers 6,000 square miles in a very rural area. And I promise you there are not protocols for caring for oral health, and we are working on it. So, healthcare professionals who are not dentists have no clue on how to provide oral care. We have no clue. Where's the roadmap? Where's the care protocol for somebody who is a family member, for somebody who's a home attendant, for somebody who's a nurse or a physical therapist, or somebody who is even a clinical psychologist who might go to a bedside, the euphemous bedside, whether it be a homeless shelter or whether it be an intensive care unit, and say, this is what, this is something that's really important. So thinking about that, we have no clue. And you can write all the care protocols you want and put them in the literature, and I'm glad they're in PubMed. But where the rubber hits the road, they're not necessarily on the front page. And I welcome all of you during the Q&A to make me wrong. I'd love to be wrong. Commandment 9, I have never seen someone with mouth discomfort who is comfortable. I've never seen it. I've never seen, and I'm a nurse, I've never seen a patient who is comfortable if their mouth is uncomfortable. They might have, all kinds of things wrong. They could be in for a fractured hip. They could be there for an acute MI. Their mouth is not comfortable, nothing's going right. And so, just asking that question and helping people think about comfort and safety, and that is so, so important. You know the data related to how oral bacteria can cause SBE, and you can end up with heart disease. That's true. But what about comfort? What about comfort and the way that somebody feels about their existence? And so I think about that a lot. I think about that all the time. And finally, the one you saw already, act like it's your mother. What would you expect if you went into a clinical setting and you saw somebody you loved and their mouth had caked on material and maybe yesterday's lunch and maybe some bleeding going on? How would you feel? How does that feel? And what do we do about it? There's an unspoken rule that you're afraid to talk about it, because if you make the nurse mad, maybe she will not like you, and maybe something bad will go on. That won't happen, by the way, I promise you that. Nurses have ethics, morals, and standards. Having said that, speak up, ask for mouth care. And I guarantee you when you do, it will happen, but the next thing will happen is they'll say, I really don't know what to do. It's also frightening when you do that mouth care because you hurt people. If you've ever begun the process of decaking someone's mouth, which I have and do regularly, what you find is that it hurts them. And so how can we be thinking about that? So today I'm all about you'll be thinking of the science, you'll be moving policy, you will change CMS, and I'm reminding you of the things that are so powerful, which is the comfort and safety and the humanism that goes on when people have great oral health. So on that note, I want to thank you for allowing the John A. Hartford Foundation to participate, for me to participate. I'm delighted to be here. Thank you for your attention this morning. Thank you.
So we're going to take a few minutes. I know we got a late start this morning, but I think we should take a few minutes to see if there are any questions for Dr. Fulmer. And, or corrections. And if you have a question, I ask you to go to the center of the room, go to one of the two mics. Please state your name and your affiliation because we're recording this and we'd like to know who you are. And I see Dr. Donoff is coming to the microphone.
Terry, good to see you and hear you again. You left out the dental profession. Do you have any comments?
I think you've got that covered, and so that's why you didn't hear me speak about it as much, because I see the extraordinary attention that goes into this from places like your shop. But I think that you bring up the good point of how many of our dental schools have specific programs related to geriatric dentistry. I've had the privilege of working with almost every one of you who have. But additionally, what are we doing to make sure that our hygiene programs have appropriate curriculum as well? So you're right to point that out, and thank you for doing that. And it's important. Hi.
Yeah, Leon Assail from Minneapolis, and that was brilliant. Just
I thought, what am I going to say to
no,
this group?
congratulations. But I think it's in counterpoint to what Mike had to say, and I'd like you both to comment on it. I think we concentrate on an oral systemic link, and that's fine. But there's an intrinsic value to oral health in the life of every human being. The mouth is an essential human organ system in of itself. And when you destroy it, you pay huge consequences in pain and nutrition and self-efficacy. The question for the two of you is, why can't we simply make that point?
Go ahead, Mike.
Why do we have to go into the arcane areas?
So actually, I don't think it's arcane, but I will endeavor to answer your question. First of all, I want to say thank you to the nurses in the room, starting with Terry. I see Maria Dolce here, and Judy Haber is somewhere in the audience. And I know there are other nurses in the room because you've done more to connect the mouth to the infrastructure, treatment system, especially in the past few years than certainly the Santa Fe group has done, but maybe large segments of organized dentistry. So we appreciate that because we dentists don't often talk to crowds as diverse as this. And I think that's our fault for not being at the table on a more regular basis. To your point, Leon, you're absolutely right. Oral health should stand on its own. You're going to hear about that today in the next session. It's worthy of support, both from private insurers and from public insurers. We don't deny that. We don't minimize that. However, in the real world we live in today, trying to get the federal government to agree to make what they will see as an investment in oral health is going to require some, I think, trading. And we have this huge database that is out there that says so much money can be saved that you can pay for the dentistry and then some. In private settings, I say, I think you can get dental care and vision care for the elderly if we were to invest in dental care at a neutral cost. If you look at the data, that's what it says. And I'll make a point I didn't make earlier. This difference is so good that pure dental insurance companies, pure play dental insurance companies are now approaching, and many of these folks are in the room, are now approaching pure play health insurers. And they're showing them their data. This is how much you can save from managing your diabetic patients, your cardiovascular patients, your end-stage renal disease patients, if you will only pay for their dental care. And what's in it for the dental insurance company? We'll manage that for you, because that's what we do well. So these effects are real. It's a tragedy that Medicaid and Medicare doesn't know that yet. I believe there is data within that system to be accessed. I'm hopeful that CMMI will request proposals to study that data, and I'm hopeful that CMMI will pay for long-term demonstration programs to show it. You're right, and I'm right. Both of these vectors are important. We have two huge reasons to pay attention, and I hope we will. Other questions for Dr. Fulmer?
Linda, I'm going to add one point to that, and then please, people are suffering. That should bother all of us. Please come to the mic, I'm ready. I just want to add that, because yes, but people are suffering. Go ahead.
Well, Terry, in the words, people who know me know I am completely obsessed with Hamilton. And in the words of Hamilton, I applaud your tactical, practical brilliance.
Thank you.
And in my experience, I agree completely with all of those commandments. What I have observed is when the head nurse on the nursing home floor, the hospital floors, committed to oral health, it gets done.
Right.
And, you know, as a dentist, I've kind of done the in-services for the nurses. What's your advice in terms of the linkage? How do we make that oral health, you know, nursing, the RNs, the LPNs, the caregivers, you know, and there is a resource of care protocols that never get down to that
Right.
street level.
Right.
How do we do that?
Thanks. And some of you know that Linda and I have also worked together for 30 plus years, and that's a great question. So nurses respond very much to things that improve the lives of patients and the reinforcement and assistance of those who can help guide them in how to get the practice completed. The reason people respond to you is because you take the time to stand there and teach them, and you go back and you give them feedback. Human beings need feedback, and it's tough work. I've never met a head nurse who said, I refuse to do oral care. They won't do that. But if you say, I'm Linda Neeson, I have a protocol, I'm happy to stop back, here's a phone number if you need me, they're not going to call you. They're just going to be so thrilled that they had access to you. So here's one of the things that was clear to me also into this moment. How do you get a dentist when you're in a hospital or when you're in a long-term care setting? How do you get one? I mean, I'm all for teledentistry if that helps me, but they're not there. There's no access for me to get it answered at the point that I need it. So I think that's a challenge for all of us. I don't have a ready, quick answer to it. We do have some nice online modules that are coming along, and I appreciate that. But I think all of us need to say, where's the access point and the feedback loop that we all respond to? A plan to study ACT, IHI, rapid quality improvement would be a really nice model. Thank you. Other questions? Well, you're off to a fabulous start, and as a funder of this, which I was very happy to do, we fund great ideas and great people. Thank you for allowing us to participate. Have a great meeting. Thank you.